just go on straight away to the thing. So specular microscopy is basically the imaging modality to view the corneal endothelium in a clinical setting or an eye bank setting. You can have it in both settings, and it's based on the same principle as you have in clinical specular microscopy, where you see the endothelium. That is, it's based on the principle of specular reflection. So the angle of reflected light makes an equal angle with the incident light, and it is only that light which can be seen, picked up by the specular microscope, and which is seen. And before I go ahead with the rest of the presentation, all the images I have of my own patients, but this is an excellent article in IGO. It's a review article by Dr. Sunita Chaurasia and Dr. Vanati, which gives you all the details of specular microscopy. So I would recommend that you go through it. If you go through that, you don't really need to go through anything else. So basically what happens is that the incident light passes through the cornea. Now the cornea is not a single surface. It has a series of interfaces which are optically distinct, have different refractive indices. Most of the light gets transmitted, some of it is absorbed and some of it is reflected back. The light which falls on the posterior corneal surface, a very minuscule part of that is reflected back. And this reflected light, which is reflected specularly, is then captured by the specular microscope and forms the endothelial image. So it's much less than 1%. Now, just to have a little bit of an idea, specular microscopes can be classified in different ways. Mostly we have in our clinics are the non-contact specular microscopes, which because the cornea is curved, cover a smaller area, or you can have the contact as well. And then you can have the horizontal specular microscopes. For example, this is a clinical specular microscope, and this is a specular microscope used in the eye bank, where you have to evaluate the corneoscleral rims. A quick view of this, I have no financial interest. Basically, this machine is very easy to use. Any specular microscope, you use it almost like an autoref. It takes very little time to capture, and the optical magnification is close to 200 times, and which is why you can see the cell so well. And once you have captured the image, the endothelial characteristics can be seen. So we need to evaluate the endothelium both in terms of qualitative parameters as well as the quantitative parameters, the numbers as well as the quality of the endothelium. And the evaluation, I thought I'd come to this later, but since this presentation didn't work, there are various ways in which you can calculate the endothelial cell density. I won't go into the details of that in the beginning, but you have a frame method where you have a frame which is put up. This may be a fixed frame or a variable frame. You can adjust the area, and then you can have the cell count taken from it. The disadvantage of this is that some of the cells which are at the border may get missed out, and you may not get very accurate cell counts. And in these cases, the variable frame method is better, right? Then you have something known as, so this is the example, this was of an adult patient donor. This is 31 years. These are eye bank images actually. And you see this is a donor as a 5-year-old child, and you see the cell count is so much higher, right? And you can see that on the thing also. And then you have the other methods where you have the flexi center method where you combine a variable frame and you can take the individual cells. This also can be taken up in multiple frames, and here you can get it. So this upper thing is showing the average. You get an average because some areas may have more cells, some may have less cells, and you can get an average of that, right? So I'll come now to the clinical specular microscopy. Now, interpreting a specular image in the correct context is important. So you cannot take anything out of context. It has to be interpreted in the clinical context as well as in the context of what other pathologies or comorbidities the patient has. So for that, it's important to know that the normal endothelium is a single layer, and it's made of polygonal cells, mostly hexagonal. And the reason why cells are hexagonal is because that is the most efficient shape, which provides a maximum area, right? So most of the cells are hexagonal. And also, once endothelial cells are damaged, usually they have poor regenerative capacity. So it's not that they don't have any regenerative capacity at all. We are now learning that peripheral cells do have some regenerative capacity, but it's a very limited capacity. And if you lose cells in the center, it's usually the migration of the cells which comes to cover up that area. And so the cell count would go down and your cell shapes would become, they would not remain so healthy, right? So this is the example. This is in fact the pictures of one of my own residents only. This is a healthy endothelium. You see this and the residents are always confused. What numbers are these? How many of you know here? Raise hands. So I'll take you through these one by one, right? So this number that you see is the number of cells which have been evaluated. 312 in the right eye and 323 in the left eye. It's only the number of cells which have been evaluated. From these number of cells, depending on the area that was taken, this is an automated analysis. You are getting the cell density. So the cell density is above 3000 and it's in cells per millimeter square. Next, you have the average. This is the average cell area. So average cell area is 300, just close to 300 in both eyes. Following this, you have the standard deviation. So how many of these cells are deviating in size from the mean? I'll come to the importance of that later. And then next is the coefficient of variation. This is one of the most important parameters. So the coefficient of variation tells you basically how variable the cells are in terms of their size, and which is also an indirect measure of their function. For example, in this, the coefficient of variation is calculated by the standard deviation divided by the average size multiplied by 100. So that's 94 here multiplied by, that's 94 divided by 329, and 34 divided by 329, that will be 28.57, right? Then you have the maximum cell area. This is the minimum cell area. And then the other important parameter is the percentage of hexagonal cells. So like I mentioned, most of the cells are hexagonal. And this parameter gives you, out of all the cells that were measured, how many cells were observed to be hexagonal. And so this is a measure of the hexagonality, and which is why its name is given 6A. So these two, the highlighted in the orange, the CV and the 6A are two. If you have to have a quick look at the endothelium, these are the two parameters you look at to see whether the endothelium is functioning well or not. Now you see here, there are different ways in this. They are just ways of showing the same image in different ways. So here we have the raw photo, the raw data. In the next image, you have the trace. So it's just traced out the boundaries of the cells, right? In the next, you have the area, right? And so these are all the same numbers which you saw on that first slide, but here this is giving you a photographic representation of these cells in area. So they're shown in different colors. There's no need to get confused with that. A particular size, a particular range is given in a different color, right? And here, this is the one which is showing you the area. So a change in area is known as polymegathism, especially if the cells become larger, right? And so a lower coefficient of variation implies that fewer cells are either very large or very small. That means most of them are optimal. And the normal CV is taken as 0.2 to 0.3, or you can take it as 20 to 30 if you multiply it by 100, because you'll get it in different values. And more than 0.4 is usually considered abnormal. Now, it's not that the endothelium is dysfunctional, but it's a sign of slowly progressing dysfunction and long-term contact lens where diabetes mellitus, you have inflammation in the eye. All these can lead to a relatively higher coefficient of variation. And the same image again represented by this one. So here, the colors are showing you the cells which were detected, which are 5-sided cells, which are 6-sided cells. And so here, it's showing you that it's a healthy endothelium. Close to 60% of the cells are hexagonal. All cells cannot always be hexagonal. There are lots of stressors of the environment as well as age-related changes. And so a count above 60 to 70 is considered usually good, right? CV is a sensitive indicator of endothelial dysfunction. If you have a very high CV, it shows you that the endothelium is a little dysfunctional. Hexagonality, on the other hand, is more of an indicator of endothelial repair. So it's been shown that if you have different shaped cells, that doesn't necessarily correlate with a badly functioning endothelium. But like I mentioned, the more the cells migrate, the more the shape will change. So you could say that a low coefficient of variation and a high 6A value are biomarkers of a healthy endothelium per se. That's what's important to remember. Clinically speaking, specular microscopy is used in endothelial pathologies. So you have primary pathologies which affect the endothelium, for example, the Fuchs endothelial dystrophy and ICE syndrome, PPCD. And then you could have any inflammation which affects, or any manipulations like, for example, post-surgery. These would affect the endothelium, and these would be classified as secondary endotheliopathies. Now, this is the image which one sees most classically. So this is Fuchs endothelial dystrophy. You need to be able to see these guttae on the slit lamp as well. If you don't, specular microscopy comes to your aid, right? So these are areas of dropout, and these areas appear dropped out because the guttae are basically excrescences of the descemet membrane into the endothelium. Normally, the endothelium reflects back light, some part of it, but the light passes through these guttae, and which is why they are appearing dark. They are not appearing bright, right? And you see multiple guttae of various sizes. Some are larger than the endothelium, some are smaller than the endothelium, and I've just shown this. So the cell density, while the cell density is still fairly good, above like 23, the CV is very high, and you're seeing that the coefficient of variation is low. So at this stage, the patient may still have a good clear cornea, but down the line it will decompensate, especially if you're doing surgery, you need to be careful. And guttae can be staged based on their size. So if, whether it's smaller than the endothelial cell, bigger than the endothelial cell, or they coalesce, right? So you have different shapes of guttae, and in some patients you may have some images which are non-analyzable. So here you have large guttae, but the cornea is clear, and in some cases you may have a non-analyzable image, which may be due to confluence of the guttae, right? So you need to be able to see that. This I've already mentioned. Corneal guttae may also be seen in some other conditions. So actual guttae you may see in also macular dystrophy, not only in Fuchs endothelial dystrophy. They're not pathognomic of Fuchs endothelial dystrophy. And the other thing is, anytime you have something on the endothelium which blocks light, you would see that as dark out areas. For example, in pigment dispersion syndrome or uveitis, if you have pigment, those cells would not be seen, which is why I said a clinico-specular correlation is important. And also, if you have uveitis, the cells can appear swollen and they can appear like pseudoguttae. They can appear darker than the normal cells. So a clinical correlation. The other condition which I find specular microscopy very useful is an ICE syndrome, the iridocorneal endothelial syndrome. So this is a patient who was referred to the glaucoma we often get patients referred from the glaucoma clinic. Sometimes the clinical diagnosis of Fuchs versus ICE can be a little confusing, because both will show you a hammered silver reflex on the endothelium, right? Sometimes, although the other features are different. And you see the specular reflex shows, so this was the typical ICE cell which was classically described for the ICE condition on specular microscopy. You see that the normal endothelium is bright and the intercellular borders, the borders are dark. But in an ICE, it becomes reverse, which is known as the light-dark reversal, and it is known as the cell surface is dark and the intercellular junctions are light. So that's very classic, and this image is kind of almost very classic of an ICE syndrome. And here, the same patient again, we can see the normal eye has a much higher cell density, whereas the ICE syndrome, the cell density is lower, and all the biomarkers, kind of markers, specular markers are altered.
Dr. Chintan, I think we have little time left.
Okay, yeah.
Am I? Yeah, you're done with actually your time.
Yeah. Okay, so I'll just finish that. And so this is a patient of uveitis where you see much less cells, right? And with a patient with Fuchs heterochromic uveitis. So I'll just finish that. Specular microscopy is clinically useful in many scenarios. So you see endothelial pathology, primary or secondary. Then following up the health of corneal transplants. As you do corneal transplantation, over years the cell count decreases to see the health of corneal transplants or status post-rejection. Determining the suitability of eyes for corneal transplantation. For a DMEC or a DSEC, you need much higher cell counts than for penetrating keratoplasties. And decision making also for in cases of Fuchs endothelial dystrophy. If you have low cell counts and a significant cataract, you might decide to go in for a combined surgery vis-a-vis if the cell counts are reasonable. So it can help you in your clinical decision making. And the last thing I think is, the slide is not there. Confocal microscopy is another view to see the endothelium. That's a perfect way to see the endothelium at higher magnifications as well.